Hi, you guys. Welcome back to a different podcast. Today we have our guest as Dr. Kamal sir, who is an anesthesiologist and DM in critical medicine at our college. And today I'm really excited that sir said yes for this podcast. And thank you, sir. So tell us about your medical journey. Where did your UG, PG, and little about your journey.
Okay. So my pursuit in field of medicine started in 2000, way back in 2008. Actually, I couldn't secure a seat in my APMC, matlab in Andhra Pradesh.
Okay.
So I did my UG in Zaporozhye State Medical University, which is in Ukraine.
Okay.
So I'm an FMG,
Oh.
and after finishing that, I cleared my entrance in my first attempt. Then I came back to my hometown, which is Visakhapatnam, Andhra Pradesh, and I did my internship in Andhra Medical College, Visakhapatnam. Then I took a drop and prepared for PG. After that, I secured anesthesia in Bharati Vidyapith Sangli. I did my PG and senior residency there in Bharati only. Then I joined as an assistant professor in near my hometown, Maharaja College of Medical Sciences, Vijayanagaram. I worked there for around 1.5 year, to be exact, 1 year 8 months. Then it was like a pit stop like thing. So again started preparing for a DM. Then I secured critical care medicine in Krishna Hospital, Karat. So I came here to do. Currently pursuing. I'm almost about to finish my first year.
That's a really good experience, and you have a lot to share, I guess, in this podcast. So let me ask you the first question. What specialty you thought when you started your MBBS, like in which branch you wanted to go, or it was always anesthesiology that you wanted to pursue?
To be frank, anesthesia was not my choice. I got it as a chance. During my MBBS days, I was always both medical and surgical. I was interested equally in both fields. So I never thought taking one branch. Never had a dream branch to be such, to be exact. Then while doing internship, that too in a government medical college, I saw the stress levels of a surgeon, surgical guy, a medical guy. Then I like actually did gave my 100% in all my postings. Gynec I used to work with PGs, night duties, everything, and surgery posting also. But while doing surgeries, at the end of the day, I feel I had a bit of what we call. I think surgery is not my branch. I'm not happy at the end of the day. I'm feeling tired. I'm not having energy to do other things. I used to think like that. That might be due to even due to the more exorbitant workload in government medical college. So I stopped thinking about surgery and started thinking of medical fields. Both because in MBBS days I always used to have that Sherlock Holmes feel. I used to enjoy like thriller movies and finding something out of the way, out of the box thinking. I think so to be very simple, only I feel what this generation should see is, are you a thinker or are you a doer? If you are a thinker, go for medical branch. If you are a doer, if you feel happy doing things, go for a surgical branch. It's just a gross division. Not that there are many fields which have growth. Almost nowadays every field has both the thinking work and doing work. So it's just a small easy division like that.
As an intern also, I am very confused which branch to take.
Okay.
Because I'm always confused whether I should go for like a workaholic life or should I choose like a work-life balance. I mean, that's the biggest question. I mean, I like gynec as a subject, honestly, but some part of me says, do I have to work that hectic hours? Do I want my life to be always working day and night, or should I go for simpler branches? So what would you suggest, or how would an intern at this place choose?
Okay, at your point of life.
Yeah.
Okay, first I'll will do this podcast very frankly and out of heart, no
Yes.
misguiding everything. First thing, work-life balance is a myth.
Yeah.
What I feel is work-life balance is a myth. The only thing which gives you happiness is a quality of life. What I feel.
Yes.
See, if you have a very good family understanding, like you being a girl, if you have understanding husband, even if you have one hour of day to spend with him, it will be you'll be very happy. But like take a second scenario which you both have a different spectrum of mind. Even if you have many hours to spend together, you guys at the end of the day won't be happy. So thing is, only like you should target quality of life, quality of the time you spend with your partner or family, not the quantity. Even nowadays in this busy world, work-life balance actually is a myth. See a top like say Mark Zuckerberg, the owner of Facebook. Does he have work-life balance? He'll work all day, all week, without any weekends. When he has time, he'll spend with his wife. But the thing is, he's having a very good rapport with his wife. So whatever the spend time together is their quality time. Okay, so quality is first important. Even if you see our Elon Musk, he does all the work. He sleeps in his office. Actually, he never goes to home also. Why unnecessary traveling? He thinks it a waste of time. He'll sleep in conference room, and he'll wake up. He'll even play games, beat high scores in online games, and challenge like online gamers. So that's his personal time. Actually, playing is his personal time, but he's happy about his personal time. So, what I'm like the bottom line is,
Quality is important.
work-life balance is a myth, at least for the 5 to 7 years of your starting of from the starting of your career, post MD, post SRship. I'm saying not from starting from MBBS, post MD. Whatever if you do MD or super specialty, the end point is MD. From that 5 to 7 years, work-life balance, achieving work-life balance is a bit difficult, more or less, but not in all fields. There are some fields which you can directly decide your work-life balance, like anesthesia, like radiology, like dermatology. You can decide your work-life this balance, but on the basis of the city which you settle, if it's a more metropolitan city, Taiwan cities, or even tier 2 cities, there will be already established doctors which you need to compete. So, like if you living a mediocre life is okay. I'm not against living, but if you want to achieve something, there is nothing like work-life balance. At least for first 5 or 7 years of your starting of from the starting of your career.
So how is anesthesiology as a career option? Can you list some pros and cons, and what should a neat aspirant look before taking the career?
NEET aspirant. So first thing, the NEET aspirant, like most of the NEET aspirants who are post interns, don't have very much idea about anesthesia, because anesthesia as a subject, it's not in MBBS
Yes,
curriculum, as I
that
know.
is true.
Now it is, has been included in competency based medical education, CBME, which is CBME. But even the branch, I mean the interns who are just finishing and giving their first attempt won't have a very great idea about anesthesia. Some might have already might their parents or some relatives might be from department of anesthesia, but anesthesia as a career option is a very good option. I don't I'm 100% sure that this is a very good option. You might ask, sir, then why did you leave anesthesia and came to do DM? But anesthesia as a career is a very good option. The only thing is, I don't want to settle at that level. I wanted to achieve something more, and more of my like so to be precise, my wife is doing super specialty. So like I never thought of that, but my colleagues motivated me.
That you should also
Sir, you
go for
also do
it.
super specialty.
Yeah.
Even I was interested in ICU care, everything. So actually I didn't think I'll get it now. I thought I'll get in the next attempt, but I just gave my exam. But by God, God's grace, I achieved what I wanted actually. So anesthesia as a career option, it's very good. So I list pros and cons separately, so that you any NEET aspirant can think whether he suits for anesthesia or not, because it's not setting the job to you, and you should fit for the job. You should be fit. Matlab, it should help you financially, mentally, physically. All you need to see. Like I will give an example. Just 10 minutes or 15 minutes before I said that, so I thought the surgery is not my branch, because I felt tired after a full day of work in surgery department. That's how in my internship I decided to a medical branch. So, a NEET aspirant who is preparing and still unsure of what branch to be taken, just pose yourself the few questions. Are you a doer or thinker? If you are a doer, you are mentally and you're physically and mentally okay for surgical branches, but I'm not saying that you're not fit for medical branches. You are fit for both surgical and medical branches. Then only just recollect your internship days. Which were the days you're happy professionally? What triggers were made you happy at that time? Just don't depend on single trigger. Take multiple triggers. What are branches you attended on internship? You'll almost attend every branch. So what branches you attended and what made you happy? Anyway, patient care always at the end of the day, patient care always make you happy. But what work did you personally enjoy doing? That's the main thing you have to do. If you may pose a question, sir, still I can't decide which branch. I like doing both OPD. I like doing both what we call as procedures, and I like to talk to my patients in OPD basis. There are even many branches like Optal, like even Ortho, ENT, even anesthesia. Don't think anesthesia doesn't have OPD nowadays. Pain medicine is a part of anesthesia. It's a very rapidly going branch of anesthesia, a sub branch of anesthesia, or to be precise, subspecialty of anesthesia. Like pain medicine, you can go ENT, Optal. There are many fields like which have both thinker and doer. Then again, you pose question yourself: are you like a secluded person, or there are some people who doesn't like to speak to relatives or patients?
Yeah.
I'm, I'm,
True,
I'm
that is
spilling the
true.
facts because
Yeah.
we should be open in conversation, because so no one should get confused. What if some even many interns, sir, I don't like to speak with relatives, sir. Counseling them is very difficult. They'll pose all irritating questions and expect us to be, like give answer everything with a happy face. Personally, to my interns, they said, sir, I don't like socializing with patients or their relatives. So there are many branches which you can take non-clinical. And again, one thing, don't think non-clinical is subpar to any other branch. It is actually many cases it is over par to clinical branches like patho, like micro, like anatomy. Whatever subject you study, if you excel in it, you will reach the top of that. You will be the apex of that. You can take any branch. Okay, so coming back to the point, if you don't like socializing and doesn't like to counsel patients, breaking bad news, you can take what we call non-clinical branches or anesthesia or radio.
So, sir, how is the pay like in anesthesia? Because a lot of students, like interns, see what is the highest paying career option.
In anesthesia or
No,
in
I'm asking about anesthesia, but comparatively.
okay, comparative, it depends. See, there are many stages. This is not a single question. There are many scenarios to this question. Like we'll take a first scenario. If you are a second generation or a third generation doctor, and you have a settled setup already, you'll directly go and start earning. You'll work under your dad or your uncle, someone, and you can start earning immediately. And coming to second scenario, the first generation doctor, and you cannot directly dive into private practice. That's a bit difficult nowadays. I'm not saying it's impossible. It is a bit difficult because I come from Visakhapatnam. It is a Taiwan city. uh, like but jumping into private practice, only few of my friends did it. One friend from dermatology, like he worked as a assistant professor for 1 year, and he opened his own clinic, and he's running successfully. So he's successful in his like terms.
Yes.
What we did is we joined as an assistant professor. I and my wife joined as assistant professor in respective departments. I am from anesthesia and she's from general surgery. The pay is equal for every subject in a medical college,
Yes.
to be precise, but not always in scenario, because if it's actually as a works as a demand and supply principle. What 10 years back, I'll say a scenario. 10 years back, no one was interested to do non-clinical branches like patho, micro. I'm very frank. To be
Even today, also, people hesitate to take non-clinical branches. It's always like second or third option when you don't get a seat.
No,
That's
not
right.
always. There are many friends of mine who like directly chose patho. They were like meant they're like they feel that they're born for patho. There are I have many friends like that because the in my like UG days they were interested in patho, and they even took they secured a better rank which could have got them like so-called better branches than patho. They're nothing like that, but she like went for patho. She's having percentages for taking patho, but she's up to patho, into patho. She finished her patho. So coming to like I think we forgot to discuss the cons of anesthesia.
Yeah.
Cons of anesthesia. First thing you need to pose questions to yourself. Can you think? Can you be mentally stable during direst situations that you have to see? Then are you okay to do a thankless job? You have to be ready for that because no one will thank you for doing your job. Your job is like a goalkeeper. People expect you to save girls,
Yes.
okay? But if you there will be some girls which you cannot save. That time you have to bear the hit, but no one will. You won't get appreciated for your work. There is a saying in anesthesia that whatever I do, no one will notice till it stops. It's a very like famous quote by a senior anesthesiologist. So like it's easy to say who shouldn't take anesthesia. First thing, if you can't think normally in critical situations. Second thing, you should be on the go. You should complete the job immediately. I'll just give an example. For example, a radiologist gets a film of, say, HRCT, high resonance computed tomography. He sees the film. He finds something absurd or something problematic with it. He might ask his senior or any other senior, sir, can you just help me out with this thing? But in anesthesia, is not the case. If you are there, you have to do it. It's only you who have to do it, and only you who can do it. So you must be ready for that situations. Then I already said it's a thankless job, so you won't get wide appreciation for the job you do, and you are in the shadow of medical field. You are not in the front face. Relatives won't talk to you. Patients won't recognize you. If you are not okay with that, better not take anesthesia. But you can take anesthesia, and there are some subspecialties in anesthesia, which you are the front runner or the show runner, like pain medicine. People with chronic back pain, chronic cervical spondylitis, all come to you for the procedure to done to get a steroid injection, which helps them to stay pain free for at least 2 to 3 months. You are the front runner there. So taking anesthesia doesn't close the doors on your face to like no have no patient interaction. You need not feel bad. Radio, you have that problem. If you don't like, my friend used to say once I took radio, my life is only black and white. I'm not seeing any colors and no patient interaction. So that's the thing. Yeah.
So when you talk about numbers, how much after post graduation does a doctor anesthesiologist earn?
Uh, I'll take my example. I studied in Bharati Vidyapit Sangli, and I went to like my hometown to settle, which is Visakhapatnam in Andhra Pradesh. Frankly, I couldn't secure a job in a medical college in Visakhapatnam. Visakhapatnam had at least 5 medical colleges, which 2 are from government side, and 3 are private colleges. I like applied for those colleges, but I couldn't get. One is for again doing my even redoing my senior residency. Though I already finished my senior residency, like I had to downgrade and again do senior residency, at least to secure a government job. I couldn't secure that, so I went to a medical college which is a city which is adjacent to Visakhapatnam, which is Vijayanagaram, which is around 50 kilometers from Visakhapatnam. Because I and my wife want to work together, so we like secured there. We both received equal pay. It's 1.2 lakh per month, 1.2 to matlab 1 lakh 20,000 per month, and we used to have ample free time. Like what you asked in the first question, work-life balance, everything. There was, to be frank, less work and more life in that. And that's my process of thinking, spectrum of thinking is like after spending 1.5 year there, we thought life was stuck. We couldn't achieve our dreams. Like My wife was always into neurosurgery. Right from her MBBS days, she always wanted to become a neurosurgeon. She took neurosurgery and she took general surgery, and we were colleagues, anesthesia, and everyone will be knowing anesthesia surgery people interaction, and we were into a relation like 3 4 years. Finally got married, and after that we settled in our nearby my hometown, which I said. So we thought of taking a gap. We didn't spend our time, never had a quality time for us. Always we used to work because we are in our residency.
Yeah.
Those 4 years, 3 years of PG and 1 year of senior residency. So we thought we'll take a leisure life for a while. We never dropped our dreams. We thought that we will
Take a break.
take
for
a
some
break
time.
for some time. We thought we'll take a break for 2 years and we will start preparing. But after even spending 1 year, we got bored. Okay, let's achieve our dreams. Then we started preparing. We both started preparing super specialty. Then we both cracked. She cracked in government medical college in my hometown, and I got in Krishna. Oh, I'm sorry about the pay. So we both used to get 1.2 lakh, which is tier. Actually, it's a tier 2 city, Vijayanagaram is, which is adjacent to a bigger city called Visakhapatnam.
Yeah.
But the thing is, that pay was only for day duties.
Okay.
9 to 4. It's a 9 to 4 duty. Night duties for at least minimum 3 to 4, 3 to 4 a month. So those who were interested in earning more or doing more, they used to do night duties outside or evening cases outside. They used to earn handsomely extra, I think around 1 lakh.
Okay.
So the starting pay you can expect is around 2.5. If you work, if you do a night duties total of 15 a month,
Okay.
and your routine work is 9 to 4, so you can earn at least 2.5. This is for anesthesia and surgery, I'm saying. Medicine also, it's almost the same. Medicine is even more because you can run 2 3 OPDs, because you won't be, once you're a starting part of career, patients won't be overflown to your OPD. So you might have 2 3 OPD setups. So medicine OPD setup doesn't require much what we call this thing. You need just your brain,
Yes.
sphygmomanometer, and a pulse oximeter, like that. And my friend used to run 3 4 OPDs. When our patients used to come, he used to go and see. He used to earn handsome salary of around 3 lakhs per month. And to be specific, he's single, so he used to work in all OPDs. So he doesn't need to denote his specific time to anyone. So he denoted all his time to his patients. Coming to non-clinical, actually non-clinical used to work, not work, sorry, used to earn more than us, to be frank. Because when I went to join that medical college, there was dire need of microbiologists and pathologists, anatomy, physiology. There was such a competition, but that they used to directly pay post-SRship 2.5 lakh per anatomy, physiology, microbiology, patho, all for, because we went to give interview at that time. Pay scale started from that point, because interviews we generally go and attend, but for anatomy, physio, patho, and micro, they will call, sir, please come, we'll pay this amount. They'll quote amount. If you're okay, sir, you come, please. There is always demand for non-clinical. I don't think it will decrease in future, because as you said, at a level, at the time of internship, everyone thinks non-clinical is a subpart to clinical,
Yes.
which is not true actually.
So, what are the other options after anesthesiology? Like, what are the super specialties you can take? Like, now you are doing DM in critical medicine. So, what are the other options that anyone can opt?
Options. First thing I need to specify is Department of Anesthesia started like Department of Anesthesia, Critical Care and Pain Medicine. All were included in anesthesia, which is a broad specialty. Then it gave a budding branches like separate pain medicine. Okay, I'll discuss in a sequence. As of now, DM post anesthesia medical, which is DM, there is critical care widespread. There are at least 250 seats per year in all DMs and DRNBs. DRNB is super specialty of DNB.
Okay.
MD, DM. MS, MCH, DNB, DRNB. DRNB super specialty of DNB. So as
So I
of
also wanted to ask what is DNB because a lot of students don't understand. Yeah.
okay, so Dr. Aishwarya is bombarding me questions in between. I'll answer in a sequence. I'll answer DNB and DRMB next to this. Okay, so coming to DM options after anesthesia, mainly there are, as of now, there are two. One is critical care,
Yeah.
which is there are recognized DM seat at least 250 all over India, both the DM and DRN, DM and DRNB. Okay, and coming to pain medicine, as of now, pain medicine is still a fellowship like thing. There is 2 years fellowship in. There is very good centers in West Bengal and Ganga Hospital in Coimbatore. There are pain medicine fellowships which is of 2 years. You have to give a pre-exam, you have to give a post-exam. It's just like a diploma after MBBS, like doing a diploma in anesthesia, which is of 2 years, diploma in ortho, which is 2 years. Like that, post MD anesthesia, you can do a FNB fellowship in national board in pain medicine. That is fellowship, and there are in central institutes there's a proper DM pain medicine as of now. There is proper DM medicine, sorry, DM pain medicine. And coming to core anesthesia, if you like don't want to leave core anesthesia, there are neuro anesthesia, cardiac anesthesia. Okay.
We have in that also.
Yeah, yeah.
Okay.
It is anesthesia is a broad specialty. Again, in that there are super specialty like neuro anesthesia, cardiac anesthesia. Yeah, you can do that. And the next question posed by Aishwarya, Dr. Aishwarya is what is the difference between DNB and MDs and DM and DRNBs? DNB is I'll say all MD is Doctor of Medicine, MD. DM is Doctorate in Medicine, which is super specialty. MS is Master in Surgery. Actually, MCH Master in Chirurgy. Chirurgy is a Russian word which actually means surgery, but to differentiate specialty and super specialty. Because I being studying in Ukraine, I know a bit. So chirurgy, which is chirurgy, is surgery only in that word. Just to differentiate, they put MS and MCH. And coming to DNB is Diplomat in National Board. See, as of now, NMC has changed. I'll say from the history. First, there used to be MCA, Medical Council of India, which has been decommissioned, and National Medical Commission came. And National Board of Examination conducts this NAT board, which is the shortcut of National Board. They conduct these exams of DNB and DRNB. DNB is Diplomat in National Board, and DRNB is Doctorate in National Board. Okay. So DNB is equivalent to MD or MS. DRNB is equivalent to MCH and DM. The bottom line is MD equal to MS equal to DNB, which is the same spectrum of degrees, and DM, MCH, DRNB are the same spectrum super specialties. Yeah.
So also now Rutika has asked the question. I will repeat the same question. So if anybody gets MD branch that they don't like, but they're getting a DNB branch which they like, so what should they go for? Should they go for MD or DNB?
Hands down, take the branch of your choice in DNB. There will be no problem. The first scenario thing, the difference between MD and DNB is a bit difficult to pass. Okay, no, not always. Now the DNB percentage is soaring very high. Almost it is now equivalent to MD. But the only thing is just to keep like a saying in your mind. In MD or MS, exam will come with an intention to pass you. It's just on a lighter vein. In DNB exam, the exam will come with an intention to fail you.
Oh.
But it's just lighter vein, it's just a joke. Nothing like that. The pass percentage of DNB has become very good. Many of my friends finished DNB surgery. The question posed by ma'am is the same thing did by my friend. He was skeptical whether to take DNB or not, but he was interested in general surgery. He took general surgery, finished his DNB, was happily working. He was my colleague in Maharaja College. So yeah.
So is there any work difference between both?
In MD, academics will be streamlined. Means the MD program in that college might be running for many years. So you will be taught at what time what to be taught. Means, for example, in anesthesia, simple cases, spinal case in first year, and GA case in second year, blocks and other pain procedures in third year. Like that, it will be streamlined in MD program. In DNB program, DNB hospitals are intended to work, so you learn by working. Now in this revolution of this internet, everything you'll find everything whatever you want on internet, which to study and what to study. There are many WhatsApp groups, senior most faculties running free WhatsApp groups on what to study. It will be helpful for you. So the answer to the question posed to me is hands down, take the branch of your choice, DNB, rather than taking a branch of uninterest in MD.
So up till now, what is the craziest case that you have seen in your medical career?
Craziest case in my medical career, craziest case. There are in anesthesia, we'll be bombarded with like not every day, but we'll get some cases which will apparently look normal when you take the case, and after that you will find something new. The one case was a patient posted for hemithyroidectomy, young female, around 25. She had a thyroid swelling, so she was posted for hemithyroidectomy by our surgery team. So once we started the case, everything went fine. After giving GA, everything went fine for first 20 minutes, and suddenly her BP started fluctuating like crust and troughs. One reading it is coming around 200, 100 again, and the reading was we were getting 70, 60. We were confused whether to give adrenaline or whether to give nitroglycerin to decrease BP. Then it was in my first year. Then I called my senior professor, sir, Dr. Lomte, and he said, like, just by seeing the case, he suspected already patient is having thyroid problem, so she might be having some endocrine problems. This much crust and troughs in BP might be pointing towards pheochromocytoma. So you prepare both drips and you insert a arterial line so that you will get beat to beat blood pressure, and you give either inotropes or nitroglycerin according to the requirement. Yeah, that's the craziest case. And after we find it crazy because it was apparently a normal case. Before we took anything, everything parameters were normal. But yeah, that's the craziest case till date.
So what would you like to say about the stereotypes of anesthesiologists? Like a lot of people say anesthesiologists are possessive to the chair because they're boring or lazy. I mean, there are a lot of stereotypes like that. So
thing like boring, nothing. But actually, yeah. To be frank, chair plays a very important role in anesthetist life. So, like in anesthesia, there is ABC. A means airway, B is breathing, and C means actually circulation. But the stereotype what you ask, they like C for chair, C for coffee. Once you give case, you need a chair to relax. Actually, once I used to see the stereotypes, used to laugh at first, but once you enter into field of anesthesia, you need you feel that is important, because once you are resting and vigilant, anesthetist requires a very high level of vigilance. You should be very alert. I learned it from my ma'am. She used to just sit like this and used to hear the heartbeat. Once any change in heartbeat, why is heart rate changing? See, is there any low depth of anesthesia? You go and see. She used to just sit outside and used to call and say. So what I feel is that sitting gives you calmness and you'll be vigilant. Once you surgeon will be doing a skill procedure. He has his muscle memory. He will be doing what he learned. He will just not just his work is also very difficult. Every work is difficult. But if he finds an artery in between, he will just bypass it and do what the procedure he is intended to do. But the thing here is the light plane of anesthesia or deep plane of anesthesia. You have to be vigilant and judging every alternate second, or every is the patient moving, is the muscle relaxation okay, Is there any increase in heart rate, which is tachycardia? Or is there any increase in blood pressure? So should I adjust the planes? So you must be vigilant. So these stereotype jokes are of old days. Nowadays anesthesia people are working in all other setups like procedural sedation, like in MRI. Yesterday your friend came for one procedural sedation in MRI. He was a bit claustrophobic, so he came.
So how many hours do you work, or how many hours does a resident work? On
Or
an average?
resident,
Yeah.
okay. So a resident, you might be seen a Hollywood movie like name Holiday, Akshay Kumar's. A soldier is never off duties. Just sing in your residency, you are never off duty.
Yeah.
You'll sometimes once you get into OT, you'll come at 2 p.m.
Yes.
2 p.m. afternoon. But there are many factors deciding you'll come 2 p.m. afternoon today or 2 p.m. afternoon tomorrow. Okay, that you have to always keep in mind. I'm saying in a like a OT perspective, like MD anesthesia, MS general surgery, MD orthopedics, and coming to medical branches, general medicine and radio, you won't be in your scrub, so you're free to, if you are feeling dizzy, if you are feeling thirsty, you can have something and come. So it's not an issue. But in MD anesthesia, surgical and anesthesia branches, once you are in scrubs, you can't go out. So actually, you should form a good team there only. Someone should to bring something, or you shouldn't starve yourself. You shouldn't dehydrate yourself. You have to be hydrated and well fed. That you can manage. But once you are into work, sometimes you won't get time to like eat or drink for 12 hours. But you'll be so invested in work that you won't feel hungry or this thing. And there are friends who can help you out sometimes. If you are in night duty, someone will bring food, whatever you need for for survival in your MD times. But the only thing I want to convey to guys who are pursuing MD or MS is however depressing thing you find, whatever how much low you attain in that point of life, always think MD MS is a phase. It's not complete life. You'll be in that phase for 3 to 4 years only. Whenever you get something like bad, you feel bad for you couldn't save a patient, something happens. Will my life be like this only my whole life? Never think like that. It's just a phase. Once you learn and achieve something, and once you get into professional life, you can manage.
So how do you relax or keep yourself motivated after such long hectic hours?
Okay, coming to hectic hours, actually, to be frank, now my DM is more hectic than my MD days. The specialty days were a bit less hectic than DM days, because these DM days we work 12 hours a day for first 15 days. Ours is a 28 day. I mean, to be 4 week cycle. 2 weeks we'll work in the morning 12 hours. 2 weeks we'll work in night 12 hours. So this is the case in DM. In my MD days, routine time is from 9 to 4, and night duty is from 2 to next day, 2 p.m. today to next day morning 9 a.m. So there is 2 hours overlap. Whatever routine cases used to go, they used to go on, and whatever emergencies come, like lower section cesarean section, appendicectomies, and any ectomies, any emergency cases, you need to do whole night. In MD, the thing is, if you are doing night duty today, there are some colleges which provide post day off or weekly once off. But in our times, if you are having a night duty, you'll work from today 9 a.m. to next day 9 a.m. Be ready for that. Okay? There is no no spoon feed, no childish things. You have to work 24 hours. But as I already said, it's just a phase. Once you get used to it, you'll be fine in first. After 6 months, you will adjust to that cycle of thing. And once you come in second year, your physical strain will be a bit less. You can start focusing more on academics, studying, and your pitfalls where you need to learn more. You can concentrate on it. Yeah.
So after your residency, now you're doing super specialty
Yeah.
DM. So what are the things that we should keep in mind before pursuing that? Or maybe just elaborate about that life, that phase of life.
That phase of life.
Preparation.
Okay. So preparation. There are okay. I'll give you two scenarios and spectrums. I'll take my colleague, who is almost 4 5 years younger to me.
Okay.
Okay. So if you see him, he never had a break. After MBS, after MBBS, he directly secured his MD, and while doing his senior residency, he secured the super specialty seat. What I did is I always used to do jobs in between. After post MBBS, I did job for 2 years, then prepared for PG. Again after PG, I worked for 1.5 year. Again prepared for DM like thing. So the thing is, there are many factors deciding your time. Sometimes you might feel I should settle early, so I shouldn't take a break. Whatever I get, I'll take this time. Whatever I get after MD, if you are preparing, whatever super special I get at the time, I'll take. Better not be that fast. What I feel is the only the thing I like to convey is work hard in internship so that whatever which branch suits you, you'll get to know. Okay. Then after doing your MD, say for example you did your MD medicine, uh, if you are very sure that I need this, I like this, I'm born for this super specialty, you can take directly. And even after MD, if you are skeptical, you can work in the respective department in any corporate college, or you can do a senior residency in respective department. For example, after doing MD anesthesia, see, I was ready for critical care. I wanted critical care. I can, because I can practice both my routine cases and ICU. I can manage both routine case and ICU. So for people who did MD anesthesia or MD medicine, and for example they want to take critical care, they are doubtful, should I pursue or not? Just give it a try. Work in an ICU for around 6 months. Then you will easily understand whether that will fit for you or not. You cannot go and fit into that. The only thing you need to see is whether that fits with you physically, mentally, emotionally, and as you said, work-life balance.
Float. Like, I thought that therefore medicine or ICU I can work in.
Yeah, the thing you ask is just like arranged marriage and love marriage. After getting married, you'll always think, why did I marry? If you miss someone you love and you marry, why did I marry him? I should have married him. And even after love marriage, and if you don't find your partner suitable, why did I marry him? I should have married. So it's always a triangle of love, arranged marriage. You'll always have that feel. That's what I'm saying. Never decide on a single day. Always give your 100% for first 6 months. Then think of it. How am I feeling? Will it be okay? Because see, first the truth beans which I spill now is, they say medicine is a service. Okay, but now seeing the outer world, nothing is a service. Everything is a paid service. Okay. In our olden days, I think 20 30 years back, there was lesser investigations. It was easy for a doctor and difficult for a patient. We know only 4 or 5 drugs. We'll give that. If it works, fine. If it doesn't work, we are not at the receiving end. Now investigations, everything has progressed so much. Thing is, we have many things in our hand, and we have to choose wisely and give it, because there is a biggest doctor in our whole world, which is Google doctor. Patient will Google, a patient or patient relatives will Google their symptoms. They will know this treatment is given, that treatment is given. So they will have a idea what treatment they are getting. And sometimes they often, why are you not giving these drugs, sir? Even patients, if we write azithromycin, for example, some smaller antibiotic, they'll ask us for Zosefta, bigger drugs. They will only ask. And sometimes we can't even deny. Because per se, if we see like a physician, he will be at a verge of losing the patient. because he doesn't want to, he had a good rapport with the patient. Always patient used to come to him. If if the patient is not prescribed what he asks for, he'll go to other doctor to bring those drugs unnecessary. I think this conversation is going out because there is something, a very big entity now, like hammering our medical field is antibiotic resistance, which has been developed over the years by misuse, overuse of antibiotics, feeding poultry with antibiotics which are non-vegetarians eat, even many things are there. That's out of the scenario. But yeah, that's it. That is it.
So what's the one thing you would like to change about the medical field if you have given the power one day? What would you like to change?
Power one day to change medical field. I'll. It should be like a balanced thing. What I feel is, people should understand that doctors are also humans. First thing.
Yes.
Next thing, though it is a bit harsh, it should be removed from services. What I feel is. Now, because now everything, the world is revolving and running behind money. Nothing will be done free. For example, you are there. You gave advice to some uncle on your phone. Will you charge anything for that? No.
Yes.
Okay. Then you go for him. He might be some lawyer, and you want some notary from him. If you go for notary, he'll charge you 500 rupees. So see, even the salary you're getting, the tax is being cut, paid to the government, and whatever you are buying, you are paying tax and buying. No one is giving it tax free. So what I feel is, the intention, the like government should take some. So you gave me the choice, but I am the supreme power. So I will make sure that it is a part. It is a paid service like thing. Just like you go to a hotel, eat, pay money, and you. It should be like this. And the same time, what I feel is a doctor is the one who gives optimal treatment without exorbitantly spending patients' money. For example, if I have all set of investigations in front of me, if you come for a simple cough, I can do every investigations. I can and I prescribe you drugs. On the second scenario, I can take a holistic approach. I can take your see your symptoms, ask you your signs, and with minimum investigations, I can optimally diagnose you. Not fully, optimally. For fully diagnosed, again you need to like do all investigations. So my theme of treating is optimally treat the patient without exorbitantly spending his money. That's the thing about a doctor.
So at the end, we are at the end of the podcast, sir. So what is the advice to the medical students that you want to give who are interns or maybe in final year?
Final year, I think I already said, but the thing is work, give your 100% in internship, work in every branch enthusiastically, and even if you are if you have the habit, take a daily diary thing, or take a note what you enjoyed working actually, whatever gave you a good feel, and at the end whenever you satisfied, what department made you feel happy. I think we missed one important thing: toxicity. Toxic departments.
Actually, thank you
Okay.
for bringing
The
that
thing
in.
is, I'll give you a scenario. Say we'll take Aishwarya name only. Aishwarya. Aishwarya is interested in XYZ branch. But when she was doing her internship, XYZ branch is very toxic. So she is in a doubt: will I become toxic like these guys? Now,
Actually, there's one branch in my mind. That is.
I'm not taking this because it again creates controversies. So I'm just saying, people are toxic there. Should I take this branch? Will I become toxic? Will I become toxic like them? Will it affect my mental state? Don't think of all this. If you like the branch, you take the branch. Even if you are getting in the same toxic college, do avoid shield toxicity. Just like generational trauma, how like we were taught to shield generational trauma from our previous generation to next generation. just shield that toxic things from your seniors to juniors.
Yes.
You don't give toxic environment for your juniors.
Yes.
It will slowly get reduced.
Yes.
So actually toxicity, the most eye-tearing things are many people suicides actually got increased.
Yes.
Nowadays. It's undeniable fact. Not in medical branch, every age group, suicide have increased. What I feel the reason is everyone is having a vivid idea how future is going to be. So thinking like that, they are like, okay, I won't go broad. I'll just say about medical field.
Yes.
They have some high aspirations. They came to college of their dream branch, and suddenly they have found toxicity, which has never been a thing to them in their MBBS days, internship or preparation.
Yes.
That's that's they will become depressed. They won't like to see it the next day of tomorrow. I saw many people getting depressed in their PG days. I have many of my friends. We used to there's a specific term in psychiatry. I think this group cheering something. Those who are depressed will sit in a group.
Group
One will
discussions,
cheer, other I
yeah.
don't feel like that. One will cheer. There is some specific I forgot. But first year all will be the same spectrum. Everyone will be facing toxicity from seniors or faculty or some girls might get some physical. There might be at a physically disadvantage at the state. This will happen, but be strong. As I said before, this is just a phase. You'll pass through it and you'll come out with flying colors. Only thing is, endure the direst situations.
Yes.
Never get depressed. Every day won't be the same day. Okay, even tomorrow is just like today. Next year won't be like this year. Na? That's you have to always keep in mind. Always develop positive mindset because toxicity is an undeniable thing in medical field. Though there might be some negative comments on this podcast, what I say is toxicity is a part and parcel of medical field. That's I can say.
So we are at the end of the podcast. Thank you for giving your valuable time. I'm really happy and excited about the podcast. How did you feel?
Actually, Dr. Aishwarya asked me 1 week before, sir, can you guide us through this internship and I would like to do a podcast about what field should we take and just you being doing MD and DM critically, you can give both outcomes and how prepared should we be to take branches. I said okay. Aishwarya is a very good friend of mine. She worked with me. And the thing is finding a Telugu girl in Maharashtra, which is a rarest thing. So she was a very good friend, and yeah, it went very good. Thank you, Aishwarya, for giving me this opportunity.
Thank you, sir. I guess that's the end of the podcast. We'll meet you in the next podcast. Bye.